going on, everybody? Welcome back to another episode of the Core Consult RX podcast. Cole, how's it going, man?
Living the dream. The dream. Oh, yeah.
Did you guys get, since I'm going to bring up the weather since you normally do, did you guys get this the bad storm that came through, the tropical storm?
So, huge change for me living here. We just got a little bit of rain, but I hear it's been pretty wild over there, huh?
Yeah, no, it was, we didn't really have much like flooding or anything like right in my general area, but a buddy of mine sent me a video from his neighborhood, and like his house was fine, but like the neighbors down the street, I mean, like their whole front yard was just underwater.
Jeez.
It was crazy.
God. What was downtown like?
I don't know. I didn't go downtown.
Okay, good.
So my car is definitely not made for.
Yeah, that's true.
It's the ultimate driving machine, apparently, but apparently not for when you're trying to go through a flooded area.
It's the ultimate driving machine for temperate climates.
Yeah, for very temperate and mild climates.
I heard there was a tornado, actually. Was there a tornado?
Yeah. There was like the Monk's Corner area, like out in the boonies. A tornado came to hit touchdown and then just like attacked an Arby's, like with a vengeance. It like just ripped an Arby's in half.
What?
And it was crazy. I saw the videos of it. I was like, man, that's so Monk's Corner to go after Arby's too.
I swear. They've got the meats.
Yeah. So definitely a lot of damage in those areas. I think Isle of Palms even had a tornado touchdown.
Jeez.
But
everybody's okay. So, that's awful.
Yeah, definitely not great to be in the middle of a tornado. I cannot say I've been in the middle of that. That would be terrifying.
I guess so. Was it a hurricane? I didn't look too closely. Tropical storm.
Yeah.
So I guess it's technically the season, but I always think of like September being when it's all happens. But I guess it is technically hurricane season.
Yeah. Plus, I mean, September is fairly close.
It's close. Yes, it's close. Yeah, that's true.
It's kind of hard to believe it's almost over. The year's almost closing down already. It's crazy. But that being said, we are doing an episode on a topic that we've done previously, maybe twice. I don't know. Definitely once that was a continuing education credit, and that has expired. And so we're going to redo it with some, any updates and anything like that. So this is another accredited episode through our friends at freece.com. And so for those of you who are already members, make sure that you go to the website after you get done listening to this episode. At some point during the episode, we'll give you a password, and you'll use that password to access the post-activity test, and then just a 10-question multiple choice exam or quiz, whatever you want to call it, and you'll get your 1 hour of continuing education credit for pharmacists and nurses. For those of you who are not Free CE members, correct your path, check them out. They have a lot of great content and lots of great learning opportunities besides just our podcasts on there. So check them out. Thanks to them for continuing to work with us. And we are going to be jumping into opioid use disorder today. So not a ton of drugs to go over, which is kind of a switch for us, but still lots of background information and context that we'll kind of talk about in a very important subject nonetheless, even though it's not as drug heavy, but definitely something that has plagued the United States for sure and other places as well. So, opioids. We'll just start off with some kind of basic background on opioids. Obviously, they're working, binding, and influencing the opioid or opiate receptor on cell membranes. And opioids themselves can kind of be divided into like three different classes. So you have like your naturally occurring opioids. So, for example, opium, morphine, those types of things are considered natural opioids. And then we have our semi-synthetic opioids, which are going to be some of the other ones that we're pretty familiar with: oxycodone, oxymorphone, hydrocodone. It also includes like heroin, for example. And then we have our full synthetic opioids. And so these are a little bit, obviously, newer agents, but that would include like buprenorphine, methadone, things like fentanyl, propoxyphene, which is no longer in the United States. That was the Darvocet. But still, those are like fully synthetic opioids. And so they're going to fall into one of those three classes typically, but we'll definitely get into more of those in a little bit. But Cole, I'm sure you got some background information for us.
Yeah, and I think at this point, pretty much everybody should be familiar with how significant the opioid epidemic is, especially in America, and how much it's impacting people. But still, I come across stats every day that or anytime I look into this, that are striking. But of course, since the 90s, opioid use and abuse have markedly risen in the U.S. A lot of factors have gone into that. One, the availability of high purity heroin, allowing people to snort it and smoke it. They don't have to intravenously inject it. Also, a campaign towards, or I should say against the undertreatment of pain, which led to a large increase in opioid prescriptions. The pushing of opioid prescriptions by, pharma companies, sales departments, maybe some misinformation about the safety of long-acting opioids. If anyone hasn't seen the documentary The Pharmacist, I think it's on Netflix. Yeah. I encourage you to check it out. It has a lot of good kind of background info on maybe the culpability of some of the pharma companies and all of that. But
you mean because oxycodone or Oxycontin, I should say, is not it doesn't have an abuse potential.
So it turns out
that whole thing.
Turns out it actually has an abuse potential.
Turns out it has quite the abuse potential.
and they didn't quite tell the truth about that.
Yeah. Whoops.
Whoopsie. Yeah. So stats, because I think this is significant. But so just in terms of population, Americans make up about 4.6% of the world's population, but consume 80% of the world's opioid supply. So that right there should tell you something's not right. In terms of hydrocodone use, 99% of the world's hydrocodone use is in the U.S. And just illegal drugs in general, about two-thirds of the world's illegal drugs are consumed in the U.S. So significant problem.
That's wild.
It's insane. That is insane. It's such a normal, like we, in dispensing, we pump out opioids, and it's just like a normal thing here for these things to be dispensed like crazy. But in other parts of the world, other developed parts of the world who have modern medicine, it's just not a thing. Isn't that wild?
Yeah, it's very strange. Especially, just overall drug use being so high in America compared to other places. It's just like with how, well off so many, Americans are comparatively to other countries. It's kind of crazy that we're still the ones that feel the need to have to abuse stuff to that extent. Yeah. There was a 2015 report that was looking at patients who were age 12 and older who admitted to using or misusing prescription pain relievers within the past 12 months. And they kind of just asked them several questions and basically were looking at, are these patients or these people who are suffering from opioid use disorder, and are they getting them from a reputable source? Are they using a street drug dealer, something like that? Interestingly enough, the report showed that 40.5% of the patients interviewed in this reported that they obtained drugs free of charge from a relative or a friend. 36.4% reported they obtained drugs through a healthcare provider via prescription. 34% reported that they obtained drugs from one doctor, and basically only 4.9% reported buying drugs from an actual street dealer or a stranger that they was not a healthcare professional. And so, that is also pretty staggering considering how heavily this opioid epidemic has kind of fallen on us. It's to think that this is actually being kind of facilitated by healthcare professionals or friends and family of the people who are using them. It's kind of wild to think, because I think I assume that people would be buying them from non-reputable sources, if you will, but it seems like it's a very low percent, at least in this one report.
Yeah, and that is a relatively old one now. I think that if nothing else, the limitations put on providers these days has to have cut down on the amount of it that is coming just directly from a prescription. But of course, people who were already, addicted and then weren't able to access them by legitimate means. I imagine now it's probably a higher rate who are obtaining, illicit drugs. But in terms of drug poisonings or overdoses, basically deaths related to opioids. It has been on the rise since 1980, but it hasn't been a consistent increase. It's really been like a logarithmic increase. In the 80s, year over year, there was about an increase in drug poisonings by about 5%. In the 90s, they were increasing by about, and that's per year. In the 90s, each year was increasing by about 18%, and it corresponded kind of directly with increased prescription opioids used for pain management. And then in the early 2000s, like the first few years of the 2000s, deaths increased by 91%. And during the same period, fatal heroin and cocaine poisonings increased by 12% and 22% as well. And to put this into perspective is in terms of how many people have been dying recently. In 2002, about 5,500 deaths were reported from prescription opioid poisonings, which was more than either heroin or cocaine, so that's prescriptions. Overall, from May 2020 to April 2021, more than 100,000 people died of drug overdoses in the U.S., record high, with synthetic opioids, mainly fentanyl, causing nearly 2/3 of the overdose deaths. All of that is very substantial. I don't know the numbers for the last couple of years, but I imagine it's pretty similar. I don't think it's gone down.
I feel like it's definitely gone up. And the other thing is, it's not just the opioid use. The opioid use, the dependence on opioids is also associated with, several other medical and behavioral health, morbidities. Obviously can have an adverse effect on, family and social circles and things. Also have legal consequences, especially when you consider like DWI and things like that can also be associated. Then we also have the infectious disease risk. So for people who are using like intravenous opioids, the bloodborne infection risk with hepatitis B, hepatitis C, HIV, obviously that risk goes up tremendously. We've talked about that at length when we've discussed Hep C in the past. For every person that is Hep C positive that is sharing a needle, on average infects 20 other new people with Hep C, which is why the age range of 20 to 30-year-olds is like actually the highest group of new cases of Hep C that we're seeing now that we're testing these younger patients. But there's some steps that we've kind of looked at as far as trying to mitigate the risk of opioid dependence. Obviously, the treatment options that are like substitution therapies that we're going to be discussing today have been helpful and have definitely helped a lot of people kind of live a normal life and keep their abuse or addiction under control and kind of at bay. But the other thing to sort of keep in mind is that these patients are oftentimes taking other medications. So things like benzodiazepine, those types of meds that can increase the risk of, respiratory depression and whatnot when you're taking with an opioid. If you're kind of reducing the number of those other medications that are being prescribed along with an opioid, that can obviously mitigate some of that risk. It doesn't take away all of it, but can definitely lower the risk of having an adverse outcome while on the opioids.
Yeah. So in terms of how these medications are acting, there are 4 major types of identified opioid receptors: mu, kappa, delta, and then one that was more recently identified, and they decided just to go totally off the rails, and they designated OFQ/N receptors. Don't know why they did that. But these are binding sites for endogenous peptides, like you would hear about endorphins. There's also dynorphins and enkephalins. I don't know how you say that, but endogenous peptides that can regulate important functions like pain, which is primarily what we're using the exogenous opioids for. Also stress and temperature, respiration, endocrine and gastrointestinal activity. They can help regulate mood, also motivation. You may have heard some of these reference with like a runner's high or endorphins that that are affected by runners and that sort of thing.
Yeah. And specifically the mu opioid receptor, I feel like is the one that I'm sure all of us are probably the most familiar with, at least hearing. There's a bunch of medications that are FDA approved, at over 20 that are available for binding to the opioid receptors, and specifically that mu receptor is a full agonist, is where a lot of the effects, the desired effects of opioids come from. So obviously the pain relief, and the euphoria or decreased anxiety, that just overall mood alteration is also a big part of the mu subtype. And then the respiratory depression obviously is a concern, because that's where, when we think of like overdose, but that's also involved with that. And then the decreasing of the gastro motility, which is where a lot of that constipation comes from with chronic opioid use. Also cough suppression. So I think that sometimes we forget that, like, Hydromed or Tussigon or something, the hydrocodone antitussive meds are effective for helping to suppress a cough, but obviously you'd have to use those very sparingly because it is still an opioid. But yes, so lots of functions at the mu receptor, and so when we start talking about some of the treatments, we'll see how some of these that mu receptor can be kind of a target, as well as some of the others, but definitely the mu will come back to.
Yeah, and it's really the primary target of abuse. Almost all abused opioids are prototypical mu agonists. The euphoria associated with the mu receptor activation is usually what is termed as the high. Opioids that are injected or inhaled can cause the levels in the brain to rise rapidly, causing a rush or a thrill. And that's a little bit different. It can give sort of a brief, intense, and usually pleasurable sensation, and that's followed by the longer lasting high. When the opioids are used chronically, there's going to be tolerance, there's going to be physical dependence over time, and with the dependence comes the need to avoid the unpleasant withdrawal symptoms. So then the drug seeking is maybe less about getting a high or getting a rush or a thrill, and more about staving off the withdrawal symptoms. They have seen that even with short-term use of opioids, there can be brain changes, gray matter changes in patients with chronic pain. In a small study, they saw long-term gray matter changes correlated with doses of morphine after only 1 month of use. Unfortunately, even keeping it to a short duration can still have long-lasting effects.
Absolutely. And there are some opioids that may be more likely to cause, at least have the potential for abuse than others. And so when we think of the more like rapid onset, short half-life opioids are definitely going to have the highest likelihood of causing addictive behaviors. And so if you think about kind of going what Cole said, if you have a patient who, let's say they're injecting heroin intravenously, they're going to have this really, very high. However, a couple hours later, those withdrawal symptoms are going to start happening. So, like Cole said, they're going to want to mitigate that, and that's where some of the drug-seeking behavior comes from. But this cycle is what kind of gets people stuck, and that eventually sends them to hopefully seek treatment, because they can only continue that path for so long before something in their life starts to kind of be affected in a negative way because of that.
Right. So for that reason, there are mu receptor agonists with delayed onsets of action, longer half-lives, like methadone, which will cause dependence, but what we've seen, they don't necessarily cause the same destructive cycle, because there's not that short-term high as much. So it can be used once daily. It can be obtained legally, and we'll talk about this as we go through the drugs to use for treatment. But once tolerance develops, it doesn't have too much of an impact on mood. Methadone doesn't. Judgment, psychomotor skills. So usually it can be used to replace the drugs that are causing a more destructive lifestyle, if that makes sense, with the ultimate goal of course, tapering them off of that at some point. But, I think there's much less of a stigma around treatment, medical treatment for opioid use disorder, than there used to be. Because I mean, I heard it from people and healthcare professionals too. The concern that you're just replacing one addiction with being addicted to a different drug, which in essence is true, but you're doing it in a controlled manner. They're getting it from a safe source, and it's less associated with destructive lifestyles that can affect them and their safety, and then those around them too. In terms of treating chronic pain in general, in 2016, the CDC did release recommendations for prescribing opioids for chronic pain in an effort to combat the epidemic of prescription overdoses. Basically, they recommended not to use opioids for first-line treatment for chronic pain. They want healthcare providers to consider non-opioid pain relievers or non-pharmacologic options. They made other recommendations about conducting a urine test before starting opioid therapy, starting at the lowest possible dose and avoiding doses that are more than 90 morphine milligram equivalents or more. And then also they recommended prescribing immediate release opioids as opposed to longer acting opioids, and limiting treatment of acute pain for no more than 7 days. So that was kind of a big thing back then. That's now 8 years ago. And so we're all kind of familiar with those ideas, especially those who interact with opioids, in terms of lowering the risk of overdose with prescription opioids.
Yeah, and Cole mentioned maintenance therapy with something like methadone, and obviously that can be used for opioid use disorder and keeping the patient away from opioids in general, but also could be potentially used for maintenance therapy of pain management too, because it can kind of help to sort of mitigate that risk of dependence and addiction. Buprenorphine is another big one that can be used in this regard, and we'll talk a lot more about this in a little bit, but buprenorphine is a partial agonist at the mu receptor, meaning that the euphoric effect that they get has sort of like a ceiling to it, and the patient can't just get this super intense high with the higher dose. They eventually get this plateau effect. Then the other thing is, it can also kind of help with preventing some of those cravings and withdrawal symptoms as well. And so there is, opportunity for some patients to be switched over from like daily opioids and to something like a Butrans patch, which, may be considered a little bit safer long-term. The buprenorphine itself binds extremely tight to the mu receptor. It's got really high affinity for it. In fact, it can bind tight enough to where it prevents other opioids from accessing the same receptor. And so it's something that if a patient is on buprenorphine and they try to use other opioids, then hopefully the buprenorphine can keep those other opioids from actually displacing the buprenorphine, and the patient won't get additional, opioids on that receptor site and those effects that come along with that. So we'll talk a lot more about that, but buprenorphine is something that could be potentially used for pain management as well, and not just treating opioid use disorder. Hey guys, I'm sorry to interrupt the episode, but I wanted to tell you briefly about our sponsor, Freed AI. Do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you are shaking your head yes, keep listening. Freed is an AI scribe that makes charting go away. It does your notes for you. Freed listens, prepares your notes, and writes patient instructions. Charting is done before your patient walks out of the room. Freed learns your style over time, just like a human scribe would. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. You can try 10 notes for free, and after that, it only costs $99 per month. You can find out more information at their website, www.getfreed.ai. Check them out today. Back to the show.
In terms of the mechanism behind opioid tolerance and opioid withdrawal, there's a number of factors at play. A few of them are, one, in response to long-term exposure of high doses or even relatively high doses of exogenous opioids, the cells will kind of internalize their mu and delta opioid receptors. So that would make it to where increased opioid levels or increased potency is going to be needed to generate the same effect on those fewer receptors. So that's going to be tolerance. In a similar way, once the exogenous opioids are removed from the system, the remaining endogenous opioids, which we referenced before, can't sufficiently activate the small number of remaining receptors. So once the exogenous opioids are removed, endogenous can't activate them, the small number of receptors, and that's going to cause withdrawal symptoms. Another factor is intracellular second messenger symptoms mediating the activity of opioid receptors are downregulated in the presence of high levels of exogenous opioids. So even the few remaining opioid receptors can't generate the response they were capable of prior to taking the opioids. So downregulating second messengers include like G proteins and adenylyl cyclase or cyclic AMP, for example. Even acute tolerance is possible, and that's mediated by changes in phosphorylation patterns and mu and delta, or phosphorylation patterns of mu and delta opioid receptors. So those are a few of the factors going into tolerance and withdrawal.
And the other thing to consider is opioids have a higher likelihood than maybe some other meds for relapse. So for patients who have struggled with addiction, maybe they've stopped using the medication, some patients for months or years, and then something will happen to trigger the desire to use the drug again down the road. In fact, there's been some animal studies that have kind of suggested that the stress levels obviously can induce a relapse, and then also exposure to conditioned cues that relate to past drug use. And then a dose of the previously administered drug or a drug with similar properties can obviously then send the person right back into that, that state where they really are desiring to get more of the medication, and they can have a relapse just from even a single dose of the medication. And so there's also some long-term evidence that shows that if you're giving opioids long-term can actually alter permanently the density of dendritic spines of certain neurons, and these changes may also contribute to long-lasting vulnerability to relapse with opioids specifically. So definitely, I think the moral of the story is we're starting to see these are not great long-term, and I think there's a lot of evidence that sort of supports that.
Yeah, they're really not. Now, it's important to point out that everyone who uses opioids does not have opioid use disorder, right? So this is a recognized mental health disorder that is diagnosable through some criteria, for instance, from the DSM-5. So I'll highlight a little bit of the diagnostic criteria because I think it's interesting. But essentially, they give about 8 or 9 criteria. You would need to have at least 2 of those criteria within a 12-month period to be considered to have opioid use disorder. So one is taking larger amounts of opioids or taking opioids over a longer period than was originally intended. Another, experiencing a persistent desire for opioids or engaging in unsuccessful efforts to cut down or control the opioid use. Also spending a great deal of time in activities necessary to obtain, use, or recover from the effects of opioids. Craving or strong desire or urge to use opioids, using opioids in a fashion that results in a failure to fulfill major role obligations at work, school, or home, continuing to use opioids despite experiencing persistent or recurrent social or interpersonal problems caused by the effects of opioids, giving up or reducing important social or recreational activities because of opioids, continuing to use them even in situations where it's physically hazardous, continuing to use opioids despite knowledge of having persistent or recurrent physical or psychological problems that are likely to have been caused by or exacerbated by the substance. I was watching a video the other day of a guy who was laid out, on the sidewalk, clearly having like an opioid overdose, and some random bystander or runner had a Narcan and, administered it, and he came back, and apparently this is a common thing after, Narcan administration, but the guy was just like so angry that she did that and was like just yelling and cursing her out and,
was
saying that, yeah, I know, messed exactly. But he was also just like yelling at her, like, you should have let me die, and
Jeez.
she just like walked away. But I was like, that's just crazy.
Yeah, that's sad. And the other thing, Cole's already mentioned tolerance, but the more of these medications are used, the tolerance does build, and usually the tolerance is obviously to the analgesic effect of one, and so a lot of patients end up having to use higher doses and taking it more frequently to get the same pain relief, as well as the euphoric effect that obviously you become tolerant of that and need higher doses to achieve the same level of euphoria. Also, besides those two things, the risk of like respiratory depression, patient can become more tolerant or reduce their own risk because their body's able to handle more of the opioids, and sedation, nausea, those types of things. The one adverse effect that doesn't really seem to ever, I guess, build a tolerance to, and when in regards to opioids, is the constipation. And we'll talk about that if we have time at the end. Opioid-induced constipation, whether you're treating someone with opioids or treating them for opioid use disorder, the constipation that it induces is a very real thing that can be very problematic for someone's quality of life. So we'll touch on that at the end.
Yeah. And then withdrawal, of course, the withdrawal phase would be where a patient has used opioids continuously. They have physical dependence, which can happen very quickly within 2 to 10 days of continuous use. When the drug is stopped abruptly, you could have withdrawal symptoms. Depending on the drug, the symptoms or the onset of symptoms is going to be different. For instance, meperidine symptoms peak at 8 to 12 hours. They last 4 to 5 days. Whereas heroin peaks at 36 to 72 hours and may last 7 to 14 days. But there's a host of symptoms associated with it, like diarrhea, sweating, shivering, piloerection, which is goosebumps. I didn't realize that the phrase cold turkey refers to goosebumps, or goose flesh, apparently some people call it.
Goose flesh. I don't think I've ever heard that expression.
I have heard it, and I think it's very strange. It sounds weird, but
goose flesh. Yeah, I don't like that.
I know. You would say goosebumps, right?
Yeah, for sure.
What do you call it?
Or piloerection.
Or the obvious alternative.
I only use medical terms.
What do you call a passy?
Like a
kid's passy.
A binky, I guess. And then,
yeah, you call it a binky, right?
Yeah, Jackson calls it a ba. So that's what I call it now. Is a ba.
It's a ba now.
Yeah, and his milk is ba. So you have to listen for the syllables.
Right. If he's continually asking for his pacifier, then you may accidentally give him the milk.
Yeah, and he's looking at you like you're crazy.
I know. Like I obviously said ba. Yeah. But also sleeplessness, restlessness, tremors, abdominal cramps, and pain, and then of course cravings for the medication. All symptoms of withdrawal.
And we've already obviously talked about the addiction piece as well, but that's where you fall into the line with the drug cravings and that compulsive use of the drug. Obviously, those patients have a much stronger tendency to relapse after they withdraw, and the addiction piece of it is trying to kind of keep their levels concentrated enough to where that withdrawal feeling doesn't actually occur. So the addiction part is what we're obviously going to be focusing on when we get into the medications of today's talk. But some other things to keep in mind, Cole's already talked about some of the withdrawal effects, but the dependence even, patients may even have signs of like depression, sleep disturbances, lack of interest. So they could easily be evaluated for like general depression, disorder, or some form of depression with anxious, distress or something like that, and maybe the opioid, not even realizing that that's being caused by this dependence and this back and forth of levels of opioids in their system. So kind of just keeping that kind of thing in mind and making sure you're doing a good med history and whatnot when you're addressing a patient that's dealing with some of this.
Yeah. In terms of what a patient is going to see when they are intoxicated with an opioid, with a mild to moderate intoxication, they're going to have what we mentioned before: euphoric effects, sedation, decreases in anxiety, a sense of tranquility, and indifference to pain. But with severe intoxication, they may have delirium or coma, and then there's also physiologic effects that go along with that: respiratory depression, which is the most dangerous, alterations in temperature, hypovolemia, meiosis. You can get soft tissue infections if it's being injected, and also increased sphincter tone, which can lead to urinary retention, interestingly.
Yeah. The other thing to keep in mind is, how quickly this dependence and whatnot can develop. There is one study that showed that patients who have been taking opioids, so a 90-day supply of opioid therapy over a 6-month period. So it wasn't necessarily, back-to-back months or whatnot, but over a 6-month period, over half of those patients remained on opioids years later if they were on 90 days worth of opioids over a 6-month period. So opioid continuation, long term, is obviously very strongly associated with opioid exposure and daily opioid doses, especially when you start talking about doses of 120 milligrams or more of morphine equivalents. It's very possible that the patient will end up having a hard time coming off of those.
Right. There's a number of other factors that can increase a patient's risk, like their social environment, if they have other psych disorders. There's even some studies to suggest a high degree of heritable vulnerability for opioid dependence, so there's genetic factors as well. But in terms of, lab studies that you'd want to order, just generally speaking for a patient who you're working up for this, of course, a urine drug screen or detection of drugs in the sweat and hair is an option to establish the issue. In the case of historical or clinical evidence of IV drug abuse, you would want to get liver function tests, a rapid plasma reagent, hepatitis viral testing, HIV testing, blood cultures, if necessary. So a few screenings to do to kind of make sure there's not other comorbidities that are underlying.
Yeah, definitely can't forget the infectious disease component with especially IV drug. All right, Cole, before we jump into the meds, we want to take a quick break into the password real quick.
That would be fantastic.
So today's password for your post-activity test on FreeCE's website is going to be OUD24. All capital letters and then the numbers 24. OUD24. If you're not a member, make sure you become a member so you can use that super secret password and you can have access to continuing education credit.
Perfect.
Yeah.
Perfect.
Nailed it.
Okay, well, let's get into the drugs, which is most of what we'll be talking about for the rest of our time here. And we've already referenced methadone. What is methadone doing? It inhibits ascending pain pathways. It diminishes the perception and response to pain. There's inpatient methadone centers. There's also specialized licensed outpatient centers, drug treatment programs that provide opioid detoxification using methadone. And like Mike mentioned, it can be a preferred agent for, or it can be an agent used for pain. Some suggest that a laboratory measure of plasma levels should be used to adjust the dose, and that 400 nanograms per milliliter is sufficient to stop cravings and drug hunger. I don't really think that's done normally, but
I've never seen that done.
I have not either. But there's a lot of benefits that we've touched on. Good treatment retention with these programs, psychosocial adjustment, and reduced criminal activity has been shown for patients treated with it as opposed to the, other opioids.
The alternatives.
Yeah.
Have you ever worked in a methadone clinic at all?
No, I've not.
I did for a while. It was definitely a good experience, and I think it made me realize too, like, I don't know what I was expecting. I guess the patient, just whatever stereotype you have in your own head. When I started meeting the patients, there were so many of them who, like, wearing a business suit and going to work. Patient hurt his back, a year ago, and got opioids for a month, and then that set him down a bad course. And it's a really like broad spectrum of patient population that's going to these clinics, but they can be life-changing for people.
Yeah.
Now, methadone is not without its fair share of warnings. In fact, it has several box warnings associated with it. I won't go into all of them, but some just to kind of note that I feel like are somewhat unique to methadone. QT prolongation that can be potentially life-threatening, and so for patients who maybe have other meds that can also prolong that QT interval, or maybe they have a prolonged QT interval at baseline, if they have like conduction abnormalities, if they're taking something that would cause, or have a situation where they have low magnesium, something like that would put them at risks for torsades, obviously we wouldn't want to take that risk into consideration. There's also a lot of drug-drug interactions with methadone. So 3A4, 2B6, 2C19, 2C9, 2D6 inhibitors all need to be used with caution, or stopping those altogether if you're going to give methadone, because there is a lot of interactions with those, with a lot of different meds, and that can increase the risk of an overdose. And then, like Cole said, the methadone can be used for pain management, but oftentimes when you see it being prescribed as a once a day dose, it should be coming from an actual certified opioid treatment program that is authorized to dispense methadone on a day-to-day basis for a patient. But if you're seeing it come from like a regular dispensing pharmacy, mostly that would be like with multiple doses throughout the day, or at least more than one, and that would be more indicative of like a pain management regimen versus opioid use disorder.
Right. I'll just highlight a little bit about its pharmacokinetics, but it has an onset of action when taken orally of about 30 minutes to an hour, with a duration of about 4 to 8 hours, but with repeated administration, it extends to about 22 to 48 hours with normal dosing. It has a pretty varied half-life, depending, but the range given is 8 to 59 hours, and it's excreted in the urine. Important to note that, so we've kind of highlighted that what methadone is used for, how it's used in the setting of the opioid clinics, or the methadone clinics. Interestingly, the established methadone clinics it's estimated that they can only accommodate about 15 to 20% of the U.S. heroin addicts. So if everybody was seeking treatment, there physically would not be enough clinics to manage them. It had been the standard of care for a long time until buprenorphine maintenance therapy came along and is kind of changing the landscape for treatment. Also important to note that I mentioned that opioid treatment in general is not as stigmatized, or at least just my anecdotal feeling is it's not as stigmatized as it was a decade ago. But specifically with methadone clinics, it can be tough, especially if the people in the surrounding area know it's a methadone clinic. The individuals have to go there every day or every week. And so you could see where there might be some hesitancy to do that due to a potential stigma. So something to note for the patients you're managing.
Absolutely. So methadone, very good option. It's been around for 30 plus years, being used in this context. But like Cole said, buprenorphine is sort of becoming a much more popularized treatment option, just because it's a little bit more flexible with how you can prescribe it, and you don't have to have the patient coming to a set clinic daily, when they're first getting on treatment. Patients that are seeing or going to a methadone clinic, they can eventually get to where they can take some of their doses home and only come like once a week, like Cole said, but it takes a while to get to that point. So for the first at least several months that they're on treatment, for a lot of patients they're having to go every single day to the clinic, so it's a lot. Buprenorphine doesn't require that close of monitoring, and remember, it's a partial agonist, so a partial opioid agonist, and it actually has antagonism activity as well, with it higher doses than at other opioid receptor sites. So it can be both the potent analgesic as well as something that can be used to block those withdrawal symptoms. The agonist effect itself does have a sort of ceiling effect, like I had mentioned earlier. So when you get into doses that are like 12 to 16 milligrams, especially higher than that, you're no longer going to produce additional analgesia, and you're basically, kind of your body cuts it off at that point, and so that you don't have to worry about some of the life-threatening complications that can arise if you continue to go up on the dose. There's lots of different formulations, and so it's something that patients can kind of find which brand name fits their needs, and there's different formulations available. So we'll talk through some of those. But buprenorphine is definitely becoming one of the go-to options, even more so than methadone, I would say.
Yeah, a couple of the interesting dosage forms are the subdermal implant, which is branded as Probufene, and a long-acting injection called Sublocade. The Probufene is injected and it's implanted in the upper arm and provides 6 months of continuous buprenorphine, which is pretty substantial. Mm-hmm. The Sublocade long-acting injection has a pretty wicked delivery mechanism. They call it an atrogel delivery mechanism, but basically it's a sub-Q injection that forms a solid mass upon contact with body fluids, and then has a half-life of about 43 to 60 days. So it would be one that's every month versus the other subdermal implant that would be every 6 months.
And again, we've already mentioned multiple times about the partial agonist activity, but specifically buprenorphine has antagonism activity at the kappa opioid receptor. So that also is one of the reasons why it cuts down on some of the side effects. Its onset of action is relatively quick. From an IM standpoint, onset of action is around 15 minutes. It can be up to an hour if given IV, and can last longer than 6 hours, especially if given IM. And like I said, just lots of different formulations to kind of fit with the patient's symptoms are, and when they're having cravings or withdrawal symptoms and whatnot. There's usually a formulation that we can find that fits the patient's needs.
Right. In terms of drug interactions, it carries the same concerns with other CNS depressants that any opioid would. So when used with benzodiazepines, muscle relaxants, other medications that depress the CNS, it's going to increase the risk for adverse reactions and overdose, possibly death. So if the recommendation is being prescribed with a benzodiazepine or another significant CNS depressant, to start with a lower dose and titrate slowly. Consider the prescribing of naloxone for emergency treatment if need be. Also has interactions with anticholinergic drugs. So we know that constipation with opioids is a significant issue. So used in concomitantly with anticholinergics can increase that risk also for urinary retention. Also has the potential to enhance serotonergic effects of drugs that can increase serotonin, SSRIs, MAOIs. So just be aware of that for patients who are at risk for that. Specifically with MAOIs, buprenorphine is not recommended during or within 14 days of discontinuing treatment.
And another kind of, I guess, weird risk associated with it is the potential for dental problems, specifically associated with transmucosal buprenorphine products. That was first... the FDA put out that warning back at the beginning of 2022, and basically were saying that, tooth decay, cavities, oral infections, even loss of teeth have been reported in patients with no prior history of dental issues. And so that's just something to at least warn patients about, maybe get them established with a dentist, and then, just giving them some counsel on taking proper care of their teeth. They also note the FDA noted that despite the risks for dental problems, that obviously that does not outweigh the benefit that being treated for opioid use disorder has. And so they're not saying that to keep people from using it. They're just trying to keep people or make sure people are taking proactive doing proactive things to hopefully mitigate that risk.
Yeah. Interestingly, so Mike mentioned, of course, that you don't have to go to methadone centers to be treated with buprenorphine, but there are some, credentialing that physicians have to go through if they're wanting to prescribe buprenorphine for opioid use disorder. They have criteria that's outlined, but essentially there is a course, like an 8-hour training course that they can use to become certified. I did not know this part, which is that they're limited to 30 buprenorphine patients in their first year. And then after that, they can apply for a waiver to increase that limit to 100 patients. And for a while, that was the limit. In 2016, they raised the limit to 275. So if you've had the limit of 100 for a year, you can apply for a waiver to be increased to 275. So this is kind of the process the patients would have to go through before they would be a candidate for the like implantable option, like I mentioned, the Probufene. And I should have mentioned before as well that it has a REMS program associated with it. The 6-month implant has a REMS program.
Yeah. And the other thing to note too is that it was April of this year that they've gotten away from requiring like the federal waiver that all providers used to have, where they would have the XDEA. So that X waiver requirement is officially gone. I guess obviously that was prohibiting access to care, and so they voted to get rid of that. So they don't need to apply for or possess that data waiver, but they obviously should know state laws still, because they may change state to state.
Right.
All right. So in 2017, the FDA put out something about once monthly Sublocade, for opioid use disorder. Like Cole said, it forms that solid mass when it comes in contact with bodily fluids. And so the drug does need to be administered in a healthcare setting to avoid inadvertent IV administration, because that can actually result in death. And so that any of these, like the Sublocade and any of these buprenorphine products, with the exception of Butrans patches, those are the ones that are indicated for pain. All of these are indicated specifically for opioid use disorder in adults. And so it's not something that you would be normally treating patients for just, pain management with one of these products. These are specifically for opioid use disorder.
Right. So that's buprenorphine by itself, and while it may have a lower risk for abuse and withdrawal symptoms, there still is that concern. So they have formulations of buprenorphine mixed with naloxone. There's a variety of them. Suboxone, you've probably heard of most often, but there's Zubsolv and Bunavail. But naloxone is, of course, a potent antagonist at the mu-opioid receptor. And it would produce withdrawal signs and symptoms in patients who were physically dependent if it was administered parenterally. So the idea is to make them not an option to abuse in that fashion, because it would kick the opioid off the mu receptors and basically put them in withdrawal.
Yeah, and specifically if they were to try to change the formulation, like if it's a Suboxone tablet or strip, if the patient were to try to melt that down in order to inject it, that's when the naloxone kicks in. So if you just take it orally like normal, then the naloxone is not a factor. So it's
right. So you could obviously take a whole bunch of it, but then you would run into other problems with
and you get that plateau effect. So don't do that.
Yes.
So lots of different studies have looked at this. There's studies looking at each of these different formulations, and basically they've all found that they've been safe for patients, and also effective at keeping patients off of opioids, and in some cases actually being able to allow the patients to taper off even the buprenorphine and get off of therapy. I will say that's not the case for everybody, and there are patients who will end up needing lifelong treatment with either methadone or buprenorphine. But they, as long as they're under the care of a healthcare professional, can have relatively normal lives, as long as they obviously stay out in front of their addictions. So definitely, just something to be aware of.
Yeah. So there's also naltrexone, which is branded as Vivitrol or Revia, which is a little bit different. It's frequently used in combination with clonidine for a rapid detoxification over the course of just a few days, but it's a very effective long-acting opioid antagonist. It was thought to be an ideal maintenance agent because it blocks receptor sites and hence, opioid reinforcing properties. But the studies weren't very promising when they compared it to methadone, for example. They found that cravings were continuing despite the naltrexone maintenance therapy. So it's not used. It's not as highly favored because of that. Interestingly, they have seen that in patients who have a high motivation to be opioid abstinent, like healthcare professionals or business executives who are being treated, they found that naltrexone therapy can be effective in those instances. But it's indicated for prevention of relapse to opioid dependence following an opioid detoxification.
Yeah, and you may even see this used for alcohol dependence as well. So naltrexone does have several different uses, but as far as like its onset of action, 15 to 30 minutes or so, with the duration of around 24 hours, and so it's usually a once a day dosing. Because there's a few different formulations of it, specifically with the deep IM injection, there's a note that inadvertent subcutaneous injection may increase likelihood of severe injection site reactions. And so the needles provided in the carton that the actual medication comes in are customized needles to help avoid that, or at least reduce that risk. Obviously, depression, suicide or suicidality has been reported in like post-marketing reports. So causal relation has not necessarily been demonstrated, but they have noted that. And then patients are also going to have vulnerability to opioid overdose, and so patients, should be alerted that they may be more sensitive to opioids, and even at lower doses. And so they need to stop. If they do stop the naltrexone and they do ever use an opioid again, they need to use a very reduced dose compared to what they think that they are used to. And then the other big thing to consider with naltrexone, and this comes up with alcohol use disorder as well, is the risk of hepatotoxicity. So if the dose increases with naltrexone, that hepatotoxicity risk goes up, and so dose-related hepatocellular injury has definitely been something that has been noted, and if the patient has any sort of signs of acute hepatitis, then we need to discontinue therapy and adjust course.
Yeah, absolutely. So I think we can finish up touching on a big side effect that we mentioned earlier of opioid use and chronic opioid use in particular, which is opioid-induced constipation, because we have some drugs specifically used for that. But acute or chronic use can lead to opioid-induced constipation through activation of opioid receptors in the GI tract, leads to decreased GI motility, peristalsis. Long-term opioid use lowers CNS depression, but does not necessarily lessen the effect on constipation. So it's usually wise to consider prophylaxis when starting an opioid regimen. First-line treatment being a stimulant laxative with or without a stool softener. Secondarily, you could consider a peripheral-acting mu-opioid receptor antagonist, and we'll talk about some of that.
And when Cole says an opioid regimen, obviously this can mean both opioid for pain regimen and also opioid for opioid use disorder. So that I feel like this is the patient population that oftentimes gets overlooked when it comes to treating the opioid-induced constipation, is the patients who are getting like methadone or buprenorphine, especially the methadone patients. Some of them have horrible constipation that is really like taking impact on their quality of life, and it's something that can easily get kind of pushed into the foreground if we're not, cautious. There are a few different options that are prescription that are obviously a lot stronger than like a stimulant laxative over the counter and stool softener. So the first one we'll talk about, Relistar, is methyl naltrexone. This is only indicated for patients with opioid-induced constipation who have already tried the OTC options, and that was not enough. And so this Relistar is either available as a sub-Q injection or an oral tablet. There have been, it's very rare, but there have been instances of GI perforation. And so if a patient has really severe abdominal symptoms, or if they've ever have history or signs of any kind of obstruction, obviously we wouldn't want to use something like this. Anytime we're giving any kind of laxative, the adverse effect that we would most commonly think of would be diarrhea. We can push the constipation too far on the other way and cause loose stool, but also GI pain, flatulence are oftentimes reported. This medication does work very quickly, especially the injectable form, and so just making sure patients are, in a place where they can use the facilities if necessary. And then if a patient does have CKD, and specifically if their creatinine clearance is less than 30, then just making sure that there's a renal dose adjustment that needs to take place.
Yeah, you never know where you'll be when the diarrhea hits.
You never know.
You never know. Another option is Movantik. Probably seen commercials for this. It's naloxegol. It also has rare instances of GI perforation. So again, use caution and look out for severe abdominal pain, and don't use it in GI obstruction. You want to use this one alone or at least 3 days before adding OTC laxatives. Similar adverse effects, possible diarrhea, GI pain, flatulence. It does have interactions with strong CYP3A4 inhibitors. With a moderate CYP3A4 inhibitor, you want to decrease the dose by 50%. So the normal dose is 25 milligrams. You want to decrease it to 12.5 milligrams. You also want to decrease the dose in patients with a creatinine clearance less than 60, so a bit of a high threshold there. And also it's recommended to take this one on an empty stomach.
And then we have another one that I maybe have seen one time, I would say in my 10 years of being a pharmacist. Simprioc is another option for opioid-induced constipation. Again, rare instance of GI perforation, so same cautions there, and then same adverse effects as far as the diarrhea, GI pain, flatulence. That one, I haven't seen nearly as much. I've seen the Movantik more frequently than that, but really, it's the alternative options that are not in that class of meds that the last three were associated with, and that's the Amitiza, which is actually FDA approved for opioid-induced constipation. You may be more familiar with that when we were talking about IBS with constipation. Amitiza tends to be, for lack of a better word, a little bit more of a wimpier option for those patients. But it is actually approved for opioid-induced constipation. My personal favorite, and one I've had success with in patients, especially with methadone, is Linzess. And so it's not technically FDA approved, but it is used oftentimes off-label for opioid-induced constipation. And there are studies that support that use. And now that it's more and more insurance companies are starting to pay for it, it's becoming easier to access. Linzess is probably one of my go-to options in this particular case, but that's just my personal opinion.
Nice.
Yes, I think we are actually over time. So anything else with this that we need to throw in the last minute?
No, I think we got to all of it.
Good deal. So thank you guys. Make sure you check out freece.com. Go get your credit. Go sign up if you're not a member. Also, if you want more structured lecture style content, check out our Patreon. It's patreon.com/coreconsultrx. We have tons of lectures on there with downloadable PowerPoint slide sets and upload stuff there. New content every month, and practice questions, patient cases sometimes, and so it's a pretty good resource if you're just looking for some refreshers on the various disease states. And then for those of you who have not checked out our partner and sponsor Pearls, pyrls.com/coreconsultrx, they're putting out all kinds of great pharmacotherapy algorithms and flow sheets, as well as charts and dosing guides and all kinds of great content. They upload stuff pretty much weekly, I feel like, and their content gets better and better. So check them out. You can download the free version of the app, and you'll get some different pharmacotherapy algorithms and flow sheets and things to keep. And then if you don't like the app, you don't have to keep using it. But there is obviously a paid version that upgrades and gives you access to all of their content. So make sure you check them out if you haven't already. And other than that, I appreciate y'all listening, and let us know if you have any questions, thoughts. We'd love to hear from you guys. And other than that, we will see you on the next episode. Have a good one.